Hi, everyone. Welcome back to our HIV 101 series on antiretroviral drug-drug interactions. My name is Alice Tseng from the Immunodeficiency Clinic, University Health Network, and the Faculty of Pharmacy, University of Toronto, and I'm part of CHAP. And today, for part 3, we're going to talk about interaction considerations with natural health products, with polypharmacy. We'll look at what DDI resources are out there and discuss a systematic stepwise approach for managing drug interactions in clinical practice. Now, just because something is natural doesn't mean it's always safe. Two, I think, very relevant examples are listed here on this slide. One is St. John's wort. It's a commonly used herbal product for treating depression, but it is a potent enzyme inducer and can cause can have significant interactions with many HIV and even hepatitis C medications. And as such, St. John's wort is contraindicated with all ARVs and hepatitis C antivirals. Ginkgo biloba is a herbal that's thought to have positive effects on cognitive functions. It also can act as an enzyme inducer. In fact, there are 2 case reports of people who are on efavirenz and suppressed, but then developed low efavirenz concentrations, virologic failure, and development of resistance after starting ginkgo biloba supplements. So, these products can have very significant effects, and you can see in this natural medicines database, these significant interactions are highlighted with both of these herbals. This is a case of a 43-year-old woman in our practice, and it's an older case, but I think it's still really informative for illustrative purposes. She, since diagnosis in 2002, she had ongoing viral replication despite being prescribed therapy because of non-adherence, lots of gastrointestinal problems, and so her CD4 was declining and her viral load was around 10,000. In September of 2009, she was started on TDF, FTC, and boosted atazanavir, and you can see 2 months later, she was virally suppressed. And then even into the next year, she remained virally suppressed. Her CD4 count started climbing up. Her total bilirubin increased. That's an effect of the atazanavir, and TDM showed therapeutic concentrations of atazanavir. So, doing really, really well. However, after being virally suppressed for 9 months, she came back the next summer, and her viral load was almost 50,000, and her CD4 count had dropped from 100 down to 33. Her total bilirubin had also dropped again, and when we did TDM, there was no detectable atazanavir concentrations. Repeat tests a month later showed identical results. And we asked this patient several times, what are you taking? And are you taking your meds? And she absolutely insisted she was 100% adherent to her medications, hadn't missed a dose of her antiretrovirals, wasn't taking any other medications. And it wasn't until a couple more months that we discovered that she had been taking activated charcoal to manage the GI upset caused by the antiretrovirals. As we know, activated charcoal is an absorbent as well as a nutraceutical. It's widely available in many natural food stores and pharmacies. A 50-gram dose of activated charcoal has a surface area of approximately 10 football fields. So not surprisingly, it's used to bind drugs in the GI tract and does a pretty efficient job of doing that. With this education, the patient did stop taking the activated charcoal, but unfortunately was unable to resuppress her virus over the next several months. By next spring, you can see her viral load had increased again, and a genotype showed a couple of new mutations despite therapeutic concentrations of atazanavir. So at that point, we had to switch agents, and luckily were able to resuppress her. Sometimes, it's not possible to find information on every single drug combination out there. So if you are trying to make an educated guess as to whether something is happening or there is a drug interaction happening, this is a really nice framework. It's called the Drug Interaction Probability Scale. So, similar to the Norano scale for adverse effects, when you're trying to determine causality of whether a drug is causing a certain side effect, this framework gives you a bunch of questions to, again, assess causality of some unwanted outcome being a result of a drug interaction, even if it had never been reported before. When we applied the scale to the situation, the result was that yes, this most likely was a probable drug interaction. We felt this was interesting enough to publish, and we even got an accompanying editorial with our case report, and I think a lot of people tend to think of case reports as kind of like the bottom feeders of published literature in terms of quality of evidence, but I think a really well-written, well-documented case report with information and using something like a causality scale can be really helpful and add to the knowledge base out there, and that's certainly what these editors suggested to help share knowledge on some of these less common combinations. Now we're going to change tack a little bit, talk about our patients getting older. And we know that polypharmacy is a concern for seniors in general. In Canada, we know that 2/3 of Canadians in the population meet the criteria for polypharmacy, which is taking more than 5 different medications, and there's also a significant proportion, so more than a quarter, meet the definition for severe polypharmacy, or taking 10 or more medications. With people living with HIV, the great thing about all the modern antiretroviral treatments is that obviously they work and people are living longer, but as a consequence of that, then there is now the increased risk of comorbidities, and this study from the United States, it was a forecasting study, showed that they're predicting by the year 2030, there would be an increase in the prevalence of most comorbidities in people with HIV. So common ones being dyslipidemia, diabetes, CKD, myocardial infarction, as well as some mental health comorbidities, and multimorbidity, so having at least one physical and one mental comorbidity, was also projected to increase from 63% of people in 2020 to 70%, which is a huge, certainly a huge proportion. In Canada, there is something called the Change HIV Cohort Study, which is a cohort of people with HIV 65 years and older. And there are contributing centers from across the country. Our former colleague, Julian Hopwood-Raja, now a great colleague, conducted this polypharmacy study where he looked at people within this cohort of older people with HIV. So 440 participants, median age of 69, an average of 26 years since HIV diagnosis. Half had comorbidity, hyperlipidemia. A significant number also had hypertension. On average, people were taking a median of 5 co-medications in addition to their antiretroviral therapies. And when he assessed the type of medications people were taking, over half met the criteria for polypharmacy. 15% met the criteria for polypharmacy. And remember, these are prescription counts, not including their ARVs. Half had at least one potentially inappropriate medication, and there was also a very high rate of use of drugs with anticholinergic or sedative properties, which are associated with risk of frailties and frailty and recent falls. On a more granular level, we have this gentleman here, 74 years old, started treatment in 1990, and the whole gamut of different types of options available in the early days. It's been virally suppressed since 2011. And you can see quite a long list of comorbidities. And his physician requested a medication review because, he's on a lot of drugs. Specifically, you can see for his ARVs include abacavir, lamivudine, dolutegravir, darunavir, and ritonavir, as well as a whole host of other medications for these comorbidities, totaling 26 pills a day, as well as 2 inhalers, 2 liquids, and 1 rectally administered product. So the physician was, perhaps concerned about drug interactions. And if you had to hazard a guess, how many potentially significant drug-drug interactions do you think are identified? Do you think we identified within this patient's regimens? And when we think about characterizing drug interactions, a lot of systems use this traffic light grading category, where red is considered a serious interaction, so you should not co-administer or cannot co-administer these 2 products together. Amber is a potential interaction where you either use the 2 drugs together with caution, do additional monitoring, or do some sort of dose adjustment, whereas a green signifies that there is no interaction that's clinically relevant. And so looking at this patient and his whole host of medications, in terms of the number of interactions identified, it actually depends on what resources you use. When we used the HIV Liverpool drug interaction guide, we found 1 red or contraindicated interaction between darunavir and triazolam, and 11 amber or potential interactions mostly with darunavir and some co-medications, also 1 between dolutegravir and calcium, for a total of 12. On the other hand, using a more general drug interaction resource like LexiDrug identified the same red interaction, but fewer amber co-medication interaction. So in this exercise, we found that the HIV-specific resource identified was more complete, while the general one included, it missed a few, and it also included certain drug interactions which were not clinically relevant or not as up to date, so it wasn't as current. However, one advantage, one additional thing that the LexiDrug drug interaction search identified was 17 interactions between 2 different co-medications. So that's a really important thing to know, is that HIV-specific drug interactions will only tell you interactions that involve at least 1 antiretroviral. They won't check for interactions between 2 co-medications, whereas a general one like Micromedics, Lexicomp, Drugs.com, whatever, they will also check for co-medication interactions. So it's really important, I think, to be aware of these limitations and to use both an HIV-specific as well as at least 1 general DDI resource when you're assessing somebody's medication profile. What about the use of artificial intelligence platforms? This was a very nice study done by my colleague Erin out in BC, called the Accurate DDI study. When the study looked at how accurate ChatGPT was in identifying and providing management advice on drug interactions compared to trusted HIV drug interaction resources like the University of Liverpool or like our Canadian HIV Hep C drug therapy guide. And what the results were was that ChatGPT only correctly classified 40% of these drug interaction pairs. So out of 94 DDI pairs, ChatGPT got it right less than half the time. Furthermore, what we found was that ChatGPT responses often contained a mix of both correct and incorrect information. It tended to underreport serious or contraindicated drug interactions and say that, okay, well, even though it's serious, you can still give them together. It also frequently overcalled interactions, so it gave warnings about non-existent or not clinically relevant drug-drug interactions. It also totally missed drug interactions that did not involve the CYP3A4 system, as well as pharmacodynamic interactions. And I think this is something that, again, is really important to be aware of, because I think we can all attest to the fact that even when it's wrong, platforms like ChatGPT sound so confident. They sound so authoritative. So particularly for lay people, it's kind of easy to be taken in. So bottom line is use more than one resource when you're checking for drug interactions. Again, product monographs might provide different guidance. So there's some country-specific recommendations, and just be mindful of the limitations of AI platforms. Putting all of these things together, how do you survive? What are some survival tips for managing HIV drug interactions in practice? I think one of the first steps I think that's really important is to obtain a complete, best possible medication history at every single visit. And things to ask about are to include not only prescription medications, but drugs that are not taken by mouth, temporary or once in a while drugs like puffers for allergy season, or antibiotics, antacids, things that people might not think of as drugs, vitamins, herbal products, supplements, complementary therapies, and then the category I like to call the do I really need to tell you drugs. Recreational agents, sexual enhancement, performance enhancing drugs. People, may be a little reluctant to disclose, but it is really important to try and ask in a non-judgmental way to get a complete history, and ask about anything that's new, that's been added, or a dose that's been changed, as well as anything that has been stopped. Encourage people to, when possible, to have all their prescriptions filled at one pharmacy to make that to make it easier to have a centralized list, and always to ask if they're not sure. Part two is just to think about drug interaction. So have that at top of mind, and it's obviously impossible to remember like every single drug interaction out there. But this is something I touched on in the very first video series. Is think about what drugs can it, what are their characteristics? Can it be a victim? Can it act as a perpetrator? So we know that with ARVs, PK boosters, lenacapavir, some of your instis, as well as fostemsavir, those can inhibit transporters. Your boosters inhibit CYP3A4. Older non-nukes act as inducers. And then you have orally administered instis and rilpivirine, which are susceptible to absorption interactions. And then think of the top red flag categories of drugs. So one study found that in people with HIV, some of the top red flag co-medication classes included corticosteroids, anticoagulants or antiplatelets, cardiovascular drugs, cations, statins, PPIs, and psychotropics. I also like to think of them as your usual suspects. So again, you don't have to know everything, but at least if you become familiar that, oh yeah, they're on an anticonvulsant or they're on a rifamycin, I should be careful. And at least, and then that gives you a hint to do some more digging. And if in doubt, look it up. There could be new information out there. It could be some obscure drug. If in doubt, look it up. I look it up every single time. Use multiple drug interaction resources, and there are some very great HIV specific ones, also some ones for other disease states like hepatitis and COVID, and then lots of free as well as subscription based general drug interaction resources. Use a stepwise approach. So, if you identify a drug interaction between two drugs, I mean, maybe the first thing to ask is, well, does this patient really need both of these drugs? If one of the drugs, like the co-medication, can be stopped, well, you can stop it and that takes care of the drug interaction. If not, are there other alternatives for this co-medication that won't interact? If so, then make that switch. If they need to be on that medication, how can we manage it? So sometimes you can change the substrate dose. You can do a follow-up plan with monitoring, counsel the patient to make some change, to be aware of what changes to be on the lookout for. And again, this is based on the time frame of DDI onset and offset. Make sure you speak and ensure good communications with other healthcare professionals involved in the patient's circle of care, so that the right hand knows what the left hand is doing. Share new drug interaction information. When possible, be as complete in your reporting as possible. There's a website called clinicalcasesddis.com where people can go online and report their experiences with a particular drug combination. You can also go and look in their database to see if anyone else has reported using a certain combination of drugs. So this is it's a nice, accessible way to get a sense of what other people's experiences are. Because we know, not everyone has time to do a full publication. But if you do have the time to publish, again, I'd really encourage that, because you're contributing to the knowledge base out there and then helping other people manage drug interactions. So to wrap up part 3 today, we talked about the fact that there are interaction risks with natural health products, polypharmacy. There can be a lot of challenges. And then your DDI management strategies, knowing what resources to use, the advantages and disadvantages of each one, and using a systematic approach and ensuring good communication. And if we had to summarize the entire 3-part series, you could think of it as how I learned to stop worrying and love DDIs. Know who your perpetrators are, your inhibitors and your inducers. Assess your arsenal. So what are people taking? Protect victim drugs and know what's at risk. Your DDI war room is going to include your solid interaction checkers, your team, your colleagues, and then be aware of all the different strategies for risk neutralization. So it is possible to manage DDIs and come into a Zen state of drug interaction management. So with that, I want to thank you for your attention and thanks for your interest in this topic, and we'll hope to chat another time.